The next talk will be delivered by Dr. Bean Ong, who is an associate professor at the University of New South Wales and a senior staff specialist geriatrics in general medicine at Bankstown-Lidcombe Hospital. He is also the director of ambulatory care in hospital in the home in Bankstown-Lidcombe Hospital, and also works as a specialist in the geriatrics and general medicine clinic. He has a particular interest in out of the hospital models of care, as well as effective collaboration between hospital and the community. Dr. Ong, the floor is yours.
Thanks, Fikari. Hi, everyone. Thank you for the invitation to present at this webinar. In this talk, I will discuss central venous access device complications in HITH and OPAT programs. And towards the end, I will present some of the work we've done on the use of infusers with peripherally inserted venous catheters. So some information on my background. I come from Bankstown Hospital, which is located in the southwest of Sydney, Australia. We service a catchment area of around 200,000 people. We are a hybrid unit comprising of hospital and home, ambulatory care, day hospital, and acute clinics. The core team members are one full-time staff specialist shared by 2 people, a registrar, a JMO, a nursing unit manager, 1 HITH coordinator, and 15 RNs. Primary health community nurses are not core members of our team, but assist us with our home visits. We also do not have dedicated allied health in our unit, but they're actively involved in our patients. As the hospital ward, we benefit mutually in working collaboratively with all hospital teams. Before I start, I'd like to provide a brief overview about our hospital antibiotic treatment. The main models are HITH and OPAT. There are some differences in how these models are organized, but the management with regards to vascular access device are similar. In this talk, I will refer to out-of-hospital treatment as HITH, which is the term we use in Australia. Treatment delivery can occur in various settings, including the home, hospital clinic or infusion center, or even a clinic elsewhere, residential care facility, and others such as workspace or schools. There's also the self-administration of OPAT aspect. The method of antibiotic delivery, recently seen done here as well, and commonly used in USA and Europe, where patients administer the medications themselves. This model is particularly suited for services that focus on long-term antibiotic delivery, probably not so much for HITH services which have a high turnover of patients. Mobile health vehicles are used in Australia mainly to provide non-acute care and clinics, but may be a useful modality for HITH in the future. Most programs offer a hybrid approach. Monitoring of the device, an important component of vascular access device management, is mostly done by the patient or carer with clinician supervision. It is also important to reflect on what is different in HITH compared to other settings. Mandatory standards of care and evidence-based guidelines, including aseptic technique, careful line management and monitoring, all does not change regardless of locations of care. HITH is multidisciplinary and there has been integrated service provision within the HITH team. The right and left hand of the service have to work in sync. Particularly for the acute patient, communication has to be effective, prompt, and timely. What is different? Patients are not in an entirely controlled environment, so collaboration and communication is harder. There's less rapid access to higher level care, so the patient's condition and clinical trajectory should be suitable to be managed out of hospital. No home is the same, so HITH clinicians have to continually adapt. Healthcare contact with the patient is limited, and accordingly, the patient plays a major role in their care. There's more patient autonomy, independence, and empowerment, and our HITH patients, our appropriately selected HITH patients, do look after and monitor this vascular access device very well. Good education and training, well described by Karen in the previous talk, of the patient is essential. Okay, vascular access devices was also well described by Karen. There is the central catheters, which can just be divided into centrally inserted catheter 6 or peripherally inserted catheters, which are the PICs. 6 ticks can be tunneled or cuffed, and which stays the longest compared to non-tunnel catheters. Subcutaneous pores last the longest. PIC is the commonest central line we use in HITH. The main lines, not quite a central line, are shorter and can last 14 to 18 days. Then there's also the commonly used peripherally intravenous catheter. Most of the time we use a short PIVC. The long PIVC is useful as they have a longer dwell time with less extravasation, but they may have a high incidence of tubullitis. Catheter complications are usually divided into three different phases: insertion, use, and removal. CVAD insertion complications are usually related to insertion technique, such as operator skill, type of catheter, and site. Risks associated with insertion of PICCs are quite low. In HITH, the two major complications we would monitor are infection and thrombosis, which have well-established benefit marks. Other catheter-related complications are also important. We do not have time to go into detail with them. I will mention a couple. Catheter migration and malfunction are quite common and can lead to serious complications. Accordingly, our nursing colleagues are very diligent in monitoring and managing this. Catheter fracture and embolization are serious complications, but fortunately rare. CVAD removal is generally managed well with current protocols, and air embolism is actually more common with 6. I will not spend time on this slide, but would say CVAD insertion complications have really been minimized over the years with the use of ultrasound and advances in insertion techniques. Most HITH services have access to a vascular access team or ICU to assist with insertion, or have dedicated members of their team who regularly insert CVADs. The related infection, one of the major complications I'll discuss can be divided into 3 groups: local exit site infection, line infection, or systemic bloodstream infection. Most catheter-related infections derive from the surrounding skin and are seen colonizers or Staph aureus. Local exit site infection respond to local measures, such as topical treatment, but prompt treatment is usually required or it will progress. Tenderness along the line usually imply a line infection or a thrombosis and requires further assessment. There may be an associated purulent exudate. We usually remove the lines promptly. Catheter-related bacteremia is the most serious event and usually defined when blood culture is positive, and ideally the culture for the catheter is positive though. It usually requires confirmation there's no other source of infection elsewhere. Catheter-related breast infections are actually quite serious. They have a high mortality and can be over 50% in ICU patients. It is also called CLEP-C when it's associated with central line, or PLEP-C when associated with PIBC. When reviewing incidents, one should look at both incidents of infection with use and incidents per 1,000 catheter days. Cuff and tunnel catheters appears to be the highest risk per device, but when you look at per 1,000 catheter days, the risk is actually quite low. PICC and midlines generally have the lowest risk of complications, with 6 highest. The above results were from a systematic review in 2006. These are poor results, and complication rates will be different depending on the setting and patient cohort. The incidence without the hospital treatment is very low. Reasons for this is multifactorial, and that the patients are less sick and there's loss of acquired infection. So when one is using benchmark, we would use this low benchmark to monitor how we are going along with our central business access devices. Improvement in healthcare and protocols have actually resulted in significant reduction in incidence of 6 in later studies. This is from a study in Spain where they reviewed data collected from standardized surveillance programs from 55 hospitals over 12 years. This demonstrated a decline in CVC infections, but PICC lines, while remaining low, may have had a slight increase. Of interest, the next chart shows a pattern of organisms over the years, showing a reduction in coag-negative Staph aureus infections and Geriatric bacilli, indicating improvement in infection control measures. I would think the pattern is similar elsewhere. So what are the risk factors for catheter-related infection? Again, there's patient factors, catheter factors, and treatment factors following the same theme. Sick patients have the highest risk. The sicker you are, the higher Apache score in ICU, malnutrition, immunodeficiency, the higher the risk. There are also catheter-related factors, including the number of lumens. Suboptimal technique, lack of sepsis, inadequate use of barrier methods, and staff queue set are obvious risk factors. Consistently across the studies, the duration of treatment is found to be a major risk factor, which one would expect. Managing catheter-related infections start with prevention. This involves strict adherence to evidence-based protocol, which every hospital should have, and also described in the Ambulatory website. This would include aseptic technique and barrier methods throughout, cutaneous antiseptics, laxative impregnable gels, encourage devices such as a scale cap, adhesive glue plug, and CVC anti-infective coating. And one should always ask, do we still need the CVAD? Close monitoring is essential to detect any potential complications, and with that, we need and involve an educated patient. When infection is suspected, prompt management following sepsis protocol is required. These may include an acute assessment and a risk assessment also if the patient needs hospital admission, blood pathology and cultures, and in most cases, parenteral antibiotics and catheter removal. If long-term venous access is still required, venous access can be via PIVC until it's safe to replace a central line. The next major complications I would like to discuss is catheter-related venous thrombosis, which accounts for 70 to 80% of thrombosis in the upper extremity. A vascular access device is a foreign body and will cause endothelial trauma, leading to inflammation, increasing risk of thrombosis. Catheter-related thrombosis can be a superficial venous thrombosis, SVT, or deep venous thrombosis, upper DVT, also termed upper extremity DVT. It occurs in 5 to 50% of hospitalized patients and 2 to 5% of ambulatory patients out of hospital treatment. Asymptomatic cases are higher at around 15 to 30%, suggesting with longer use, a silent thrombus can progress. Fortunately, pulmonary embolism and post-thrombotic syndrome, significant complications occur at a much lower incidence than DVT in the lower extremities. And talking about risk factors, vascular access device is itself a foreign body, as mentioned before, and it causes endothelial injury. So manipulation should be minimized as possible. Patients who are sick, has cancer, especially in the advanced stages, coagulopathy, significant infection, and are obvious risk factors. Site of the catheter may be relevant, particularly if there's form of pain. The catheter to vein ratio should be 45% or less. Number of lumens is also another risk factor. So we would avoid using more lumens than we require. Tip out the cerebral cable or cable atrial junction confers the lowest risk. Midlines are reported to have the highest risk, with 6 the lowest. As with catheter-related infection, correct incision techniques and experience reduce risk. Common drugs such as ampicillin and gentamicin actually can cause endothelial toxicity, but in more cases, it's not severe enough to be a clinical problem. The second drugs such as flucloxacillin and vancomycin confer a high risk and is not uncommonly associated with thrombosis. Risk assessment scores can be useful in predicting risk, and the Michigan risk score mentioned there is the most commonly used. So how do you manage catheter-related thrombosis? Again, prevention. As with catheter-related infection, good adherence to a strict protocol is essential, as well as awareness of management of risk factors if possible. Prophylactic anticoagulation is not routinely recommended, but can be considered in high-risk patients. We depend on the patient for close monitoring and early detection, particularly of pain or swelling. Other suggestive features include catheter malfunction, delayed emptying, and occlusion. If this occurs, ultrasound is a diagnostic test of choice. If the DVT is found, the treatment is anticoagulation as per standard protocol. SVTs are usually treated with a lower dose anticoagulation unless it's persistently symptomatic or appear to be progressing. We prefer to remove the line if it is symptomatic, but if the catheter is functional and there's difficult access, some people do leave it in. Catheter thrombolysis is rarely used, as anticoagulation is quite effective. Ongoing quality assurance of a CVAD practice is essential. We continue to review it, and over the 2 years of 2022-23, we treated a total of 245 patients with central catheters and midlines out of a total of 1,000 HITH patients. Majority of these are PICC lines with few midlines. There was a suspected PICC site infection. The site was inflamed, but the CRP was normal, catheter tip and blood cultures are normal, and the patient resolved promptly when it was changed to oral antibiotics. There were no bloodstream infections. The thrombosis rate was 1.6%. But of the 8 midlines, we have 1 thrombosis with a midline thrombosis rate of 12.5%. This is consistent with the literature for those 2 years. And obviously, it does not stop there. Ongoing review is required. We keep our database well centralized and review the complications, add-on mortality, and morbidity meetings regularly. So moving on to the next part of the talk, CVADs are effective, but they have limitations in the use in addition to complication rates. So it sort of leads us to explore if we can extend the use of the standard PFAPC. And the drivers include the need to use higher doses, where frequent dosaging is not possible in HITH, particularly with capsaicin doses of 6 grams and above, though. And this antibiotics is for short term, where midlines and peak lines are not recommended. And also at times we need to start antibiotic use promptly while we think peak line insertion without a need for hospital admission. There's also the positive experience of the use of electronic infusers via PIVC elsewhere. A lot of it anecdotally, but there have been a few publications. And we know that the use of infusion devices in hospital setting where required is standard practice. There are theoretical concerns from a few doctors about the risk of extubation in its management in the out-of-the-hospital setting, and we acknowledge that. But however, up to now, we have not found that to be a major issue. We will show subsequent later. So I think this was presented at the Australasian Hospital and Home Conference last year. We have developed strict criteria accordingly to start with. We currently only use capsaicin and tazocin, which is piperacillin and tazobactam elastomeric infusers. We will restrict the practice to patients who attend our unit daily until the practice is more established and we have clearer guidelines. There has to be good venous access, and we mainly use the forearm veins, though we occasionally do use the veins in the hand. As always with HITH treatment, cognition and physical ability is required, as well as compliance and consent. There is also the patient preference for daily treatment in the unit, and also out-of-area patients who prefer to continue treatment with us. And it's also another useful modality when community nurses were not able to do home visits with capacity constraints. Patient education and training, as always, with HITH is mandatory. We do have a daily nurse review, and our unit staff is contactable until 9 p.m. weekdays and 6 p.m. on weekends. We do not have an after-hours service, and if there are problems after hours, the only option is ED presentation. We usually remove the cannula when we suspect pulvitis is developing. So the most commonly treated diagnosis was cellulitis and skin and soft tissue infections. A small proportion have joint or bone infection. The majority of patients, 85%, were treated with capsaicin, with 15% treated with piperacillin and tazobactam, which is tazocin. The average treatment is around 5.5 days. The PIVC dwell time is 2.58 days. As with any PIVC use, there are incidences of pulvitis and leaking. And overall, there were 20% incidence, which compares favorably to the non-literature rate of 50%, around 50%. Majority of these were managed with the daily review. Unplanned presentations related to the catheter to emergency department only occurs once or twice a year, and these were generally resolved with PIVC change and recommencement of HITH treatment. So the overall results have been quite reassuring. Our patients have monitored their PIVC very well. In the middle, you can see the VIP score we use. If you have a score of 2, would be classified as phlebotomist. With this, the incident rate for phlebotomist is low at 20.8% per 1,000 catheter days, and also comparing favorably to loan literature. For serious complications, we've had no cases of catheter-related bloodstream infections or thrombosis. On completion of the program, there are about 7.8% readmissions, but none of these were related to PIVC complications. The main advantage of expanding the HITH service using the elastomeric antibody infusers of PIVC was the impact on avoidable hospital bed days. Over the years, we've treated over 720 patients with the equivalent of 3,900 catheter days, corresponding to 2,900 bed days saved and 528 days per year. So we are continuing this practice. So in summary, there has been significant advances in the management of CVAVD over the years. Complications are uncommon, but can lead to significant morbidity and mortality. Management of the central venous access device in HITH requires knowledge of protocols with emphasis on appropriate use, aseptic technique, careful line management and monitoring, prevention, early detection and management of complications, as well as ongoing risk-benefit assessment of CVAD use. Quality assurance requires monitoring of major complications against available benchmark and an ongoing system improvement. Engagement and education of the patient are key factors in successful HITH management. And the use of infuses via PIVC is a promising modality, but requires cautious supervised use and further research delineating its role in HITH. I would like to acknowledge my colleagues, Solly Joseph, HITH coordinator, Josephine Master, my nursing unit manager, Kathleen Brennan, our ICU nurse practitioner, Dr. Ravindra Dotel, our infectious disease physician, Dr. Vincent Nian, my colleague, and Dr. Fiona Tran, our medical assessment unit specialist. And as always, it's always good to collaborate, and if people like to contact me, my email address is below. Okay, thank you. And any questions?
Thank you very much, Dr. Ong.